Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hi, everyone. Welcome back to the Breast Cancer Podcast. I'm here today with Dr. Santosh Kale. He's a plastic surgeon here in Columbus, Ohio. And I'm very fortunate to work with him as he's talking about all these innovations in the deep reconstruction space. What is deep reconstruction, Dr. Kale?
Yeah, so let me share a photo.
Okay.
So, okay, so deep flap reconstruction is using someone's own tissue,
Okay.
specifically from the lower belly tissue,
Okay.
to replace the breast tissue after a mastectomy.
Okay.
So using someone's own fat to reconstruct their breast.
Okay.
And in this picture here, you see the tissue from the lower belly. You see the blood vessels going into the tissue to keep the blood vessels alive, so that we can then transfer that tissue to the chest and reconnect it to new blood vessels in the chest.
Wow. Is there any other type of reconstruction that you perform?
So yeah, we also perform implant-based reconstruction,
Okay. Okay.
in addition to tissue-based reconstruction, and we also sometimes use a combination of implants and tissues. Sometimes we participate with you guys
Yeah.
doing the Goldilocks procedure,
Yeah.
where we're using extra skin to reconstruct
Right.
their
Right.
breast.
Yeah. Yeah.
And sometimes we use fat grafting alone.
Yeah,
Yeah,
yeah, yeah. I have. I mean, we do a lot of patients together, and
right.
we've really had good outcomes. And you guys are like very high volume, deep reconstruction surgeons. You said earlier you perform about 2 to 5 deep flaps a week.
That's about
Is that
right.
correct?
Yeah,
Wow.
yeah,
That translates to up to 240 deep flaps in a year, and that's a pretty big volume.
right.
And what's some criteria when you select a patient who can undergo a deep reconstruction?
So, for anyone undergoing autologous reconstruction, so tissue-based reconstruction, key things that we look for are we want to make sure that that patient is their heart and lungs,
Mhm.
they're strong enough to be able to tolerate a slightly longer general anesthesia.
Yeah.
We want to make sure that they have extra tissue to give. We want to make sure if they've had any surgeries before in the areas where we would borrow the tissue from, that those surgeries don't negatively affect our
Yeah.
ability to transfer the tissue.
Yeah.
So, for instance, some patients have had abdominoplasty or a tummy tuck before,
Yeah.
in which case, the belly tissue, it would be pretty difficult for us to be able to use um, performing a deep flap reconstruction.
Yeah.
So, so those are the main things that we
Yeah.
look for.
Yeah.
Yeah.
And I know we talk about, when I'm sending you patients to talk about deep reconstruction or implant-based reconstruction, back of my mind, I'm thinking if someone has had radiation or going to get radiation, I'm thinking deep reconstruction. Would you agree with that? Or would they have any other options besides a deep reconstruction?
Sure. I would
Yeah.
say, radiation, it's difficult. So
Yeah.
first, it's a necessary
Right.
for
Yeah.
treatment of some cancers,
Right.
right? Um, not everybody's response to radiation is the same.
Yeah.
We have some patients that it's hard to tell that they've had radiation.
Yeah.
And we've had some patients where they have very severe changes to radiation, where
Yeah.
you experience pigment change, skin tightening, um, all those kinds of
Yeah.
things. So for patients that are on the spectrum where they have very subtle changes,
Yeah.
you can safely do an implant-based reconstruction. Now,
Yeah.
the risk is a little bit higher had they not had radiation, like risk of infection and
Yeah.
capsular contracture, implant exposure, but it's still an option nonetheless.
Okay.
But I would say, generally speaking, if someone's had radiation, I would say tissues can be more reliable
Yeah.
than implants. And, the other end of the spectrum, if someone has very severe changes, then it would be very difficult to do an implant only based reconstruction, in which case we'd have to use some form of autologous
Yeah.
reconstruction.
Yeah.
So,
That makes
right.
sense. So, has there been any updates or innovation in the deep reconstruction space?
Yeah. So, one thing in particular that our group is really excited about is that one of the things that we try to do with every patient is we try to preserve the nerves. So before I kind of go into that, one thing I want to kind of briefly go over the history of deep flap surgery, which is, before the deep flap, there was the TRAM flap. And with the TRAM flap, what that meant is that six-pack muscle was sacrificed in transferring the tissue from the belly to the breast. And as a result, patients had to have mesh, they could have bulges,
Yeah.
hernias, pain in their belly, weakness in their core.
Yeah.
So then comes along the deep flap. And what the deep flap is we're leaving the muscle behind, taking just the skin and fat on a few of the blood vessels that keep that tissue alive rather than all of them with the tram flap. So we're saving the muscle um, to then transfer the tissue from the belly
Yeah.
to the breast. Now, in a nerve sparing deep flap, we kind of take that just a step further.
Yeah.
And that is when we are, so I want to share a picture with you.
Okay.
Okay, so when you your six-pack muscle, it's a segmentally innervated muscle, which means that it's divided into segments, and those segments have different nerve fibers that connect to it that allow the muscle to function and work and to maintain a resting tone. So when you look at the deep flap, what you see here is you see the skin and fat. You see the blood vessels going into the fatty tissue, and you can see them as they branch into the tissue to uh, spread blood, uh, both going into the tissue and out of the tissue to all the areas of the flap itself. Then if we follow those blood vessels, we see that it goes down to the muscle. There's an opening in the muscle, and generally those blood vessels travel behind the muscle, which is where we disconnect the blood vessels from its anatomical blood supply in the belly. The reason we have to go behind the muscle is because we need to get sufficient length of those blood vessels, and we need to get the appropriate size to match the blood vessels in the chest. So that's typically why we go behind the muscle. Now, in the process of dissecting around the muscle, so we're preserving the muscle, but we're dissecting around it, we sometimes encounter those nerve fibers. So you can see them here in those pictures. We encounter those nerve fibers as they cross over the blood vessel. And so one thing that we try to do in our nerve sparing deep flaps is that we try to preserve the nerves as they cross over those blood vessels. And by doing so, we're kind of taking that deep flap a step further in that we're not disconnecting the muscle from its nerve supply. That muscle can, as it recovers, it can maintain its tone, it can
Yeah.
recover more towards its original state. So from a function standpoint, from a abdominal contour standpoint, it kind of preserves the integrity of that muscle.
Yeah, that is incredible to think of this. When women are having this surgery, there's an incision at the bottom portion of your belly.
Right.
And sometimes when you're doing crunches, whatnot, you may or may not be able to feel the contraction of the muscles. But I imagine with something like this, you should be able to better work out your core muscles.
That is the ultimate
That's the whole goal for
Yeah,
this. Okay.
correct.
Yeah, that's wonderful.
Correct.
That's wonderful. I'm just really fascinated on how, I don't know if you knew, like the reconstruction really did not start having all these innovations till like late 1970s. Did you know that?
Right.
Yeah. So, but within the last, 30, 40 years, we have come, so far along where women were having a radical mastectomy where we remove not only the breast tissue, but the muscle. So they just had the skin over the ribs. And that created a big deformity to where now women can have different types of reconstruction. We're preserving the muscle, we're preserving the nerves, and then doing plastic surgeons like Dr. Kale and his partners perform deep reconstruction, not only where there is nerve sparing, but there's rib sparing. And we have really come a long way. And for you to offer this to our patients, I feel really lucky to have you, to work with you, and for patients to have this type of option.
Well, likewise, yeah.
Yeah,
And one of the goals of plastic surgery is to restore to normal.
correct.
And there are some things that will change in the belly region when a patient has a deep flap, but we try to minimize those changes as best as we possibly can.
Yeah, that is really great.
Yeah.
Thank you so much, Dr. Kale.
Thank you, Dr. Halaharvi.
Yeah, thank you for taking the time to be here. And for our listeners, if you want to find out more about this type of reconstruction, when you talk to your surgeons, ask if they perform these procedures. And you want to empower yourself, you want to advocate for yourself. And that's the whole goal with this podcast. This podcast is in 127 countries. So when you seek out a plastic surgeon, you want to seek out someone who is trained in plastic surgery, but also micro trained if you're wanting to get autologous reconstruction or using your own tissue for the plastic surgeons to perform your reconstruction. They also need to be microsurgery trained. And I feel really grateful to have Dr. Kale here, his partners, Dr. Tiwari and Dr. Kochak. They perform this procedure up to 240 DIEP flaps a year, which is a pretty big number. And they're really good at what they do. And I believe you had said at the earlier podcast that your flap loss is like around 1%. Is that correct?
Correct.
Yeah. Across the country, it's around 5%. So you can tell just doing the big volume of these procedures does make you good. And, you have good outcomes. So thank you so much for joining us today. Always empower yourself, educate yourselves, and then that way you can advocate for yourself. So, all right, everyone, if you like this podcast, please share with your friends and family and give us a 5-star rating. And until next time, see you later. Bye-bye.
Bye.
Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.